Hey everyone, hope you're doing well. Dr. Nate Lighthizer here from the NSU Oklahoma College of Optometry. Again, hope you guys are enjoying your day, enjoying your new year. Talking on a case on diabetic retinopathy here and how the ERG helps us in that particular types of cases, among many, many others. So this was vision complaints reflected on the ERG. And a little bit about me. I'm here at the Oklahoma College of Optometry, been the chief of electrophysiology from 2010 to 2018. I then passed it on to my understudy, Dr. Neil Whittle, but still involved in our electrodiagnostics clinic and specifically with the RETeval since 2023. It's been amazing in our clinic. I'm in diabetic clinic every Wednesday morning, and we run it on every single diabetic patient. So it's just an awesome test, as you all know, to be able to take this right to the patient and gives us objective functional data to pair with our OCTs and fundus photos that, again, you guys all know so very, very well. So again, my protocol, any patient that has ocular pathology where we need functional information, if they're a diabetic with any degree of structural changes, any degree of vision that is reduced, whether that's objectively on the Snellen vision chart or subjectively, they just say, I'm just not seeing as well as I used to, doc. My vision is just not right. I'm not happy with my vision. Maybe it's nighttime vision. I can't see as well at night, doc. Colors look different, doc. Again, anything like that, color vision is down. We will run the ERG. Again, flow is so easy as we've discussed. So, case report, how ERG helped me motivate, a patient, 77-year-old male. He's diabetic for the last 19 years, last A1C 8.2, controlled with oral medications. And you guys know just as well as I do, how likely, that's an elevated A1C. 8.2 is higher than we would like it. Maybe let's talk to this 77-year-old male about diet and exercise and changing habits. How likely are you going to change the habits, the diet, or start exercise in a 77-year-old male? Good luck. It's probably not going to happen, but you can always try. So, type 2 diabetic, 19 years, A1C 8.2. In vision, you can see there 20/20 minus in the right eye, 20/30 plus in the left eye. His chief complaint is, I'm just not quite seeing as well in my left eye as I have in the past. So that was the chief complaint, and visual acuity match. You take a look at the back of the eyes, you take a look here and, notice overall for a long-standing diabetic, 77-year-old male, been diabetes for a couple of decades at this point, A1C of 8.2, it doesn't look bad. We've got mild non-proliferative diabetic retinopathy in the right eye, a couple very small microaneurysms, as you can see here, nothing severe, nothing, nothing that's really, really, really concerning. But again, my vision's down in the left eye, 20/30 plus in that left eye, and we have structural issues. We've got a functional complaint. Doc, my vision is down. Vision is down on the Snellen chart. We've got some structural changes in the back of the eye. We have multiple reasons why we need to run an ERG in this particular case. OCT, again, you take a look at this OCT in the right eye. The right eye was 20/20 minus, looks pretty good. How about the left eye? The left eye was 20/30 plus, but these OCTs look the same between the right eye and between the left eye. There's no difference here. So for 20/20 minus in the right eye, we'd expect to be 20/20 minus in the left eye, and we're not at this point in time. So again, OCT, you got to do it. Gives you wonderful, wonderful structural data, but it doesn't tell us the entire picture in this particular case. You take a look and you see the ERG with our RETeval, our DR score, doing our DR assessment protocol, and you take a look and it's not terrible. It's not that terrible. This is what I would call a borderline DR score, a borderline DR assessment result. The time, it's on the slow end, between 0% and 100%. The lower the number, the better. You can see we're on the high end here. We're pretty slow with this one. How about the strength? Again, that percentage, 0% to 100%. I want to be on the high end for this one. So again, 90%, 80%, 70% would be wonderful for the strength of this. And you can see we're a fairly low percentage in the right eye, a little bit better in the left eye, but again, still on the lower quartile. So it's not terrible, but this is saying, you know what? We should have a better ERG than we'd like here. We'd really like to have a better ERG here. It's borderline. It could be worse, but it certainly could be better as well. Those implicit times are flagged. We have got some cellular stress. So again, I start by looking at the overall score. Okay. As you know, the lower the number, the better. 23.5 is kind of the cutoff. The higher the number, the worse it gets. If it's in the teens, I'm like 2 thumbs up the vast majority of the time. Kind of that 21 to 23 is what I clinically consider borderline. That's kind of borderline. That's where we're at here. But that's the overall summation. That's the overall number. But then I also look at, again, looking at that individual, the times in the right eye, the strength in the right eye, the time in the left eye, the strength in the left eye. Again, not terrible, borderline results at this point. So, talking to this patient, letting them know, I always tell them, I tie this back to the EKG because all patients understand what an EKG is. They just do. They've had them before, especially as these patients get into their 50s, 60s, 70s, 80s, and beyond. And, 77-year-old, as I said before, he's not motivated to change his diet. He's not motivated to change his A1C, whatever. He's like my grandfather who's 97. It is what it is. I'm going to eat what I want, sonny boy, at this stage in life. But he was amenable to taking a supplement for retinal health because he's unhappy with his vision there. And we're going to see this patient back. This is not going to be quick changes. Things change pretty slowly in diabetes, usually, not always. There are exceptions to that. But you're going to see this patient back instead of in a year. Let's see them back in 6 months. And let's see how it's doing. He's using the supplement regularly. I've seen him multiple times over the years. A1C didn't change, 8.2 to 8.2. He's eating whatever he wants, but you'll notice what his ERG did over the course of that 1 year later. And you can certainly see an overall better number from in the 21s to in the 19s. And those waveforms just look stronger, just look better. Doc, you are helping this patient. If your cardiologist got your EKG functioning better through diet, exercise, medications, supplements, interventional surgeries, whatever it is, they're doing their job. You get them doing the EKG of the back of the eye, the ERG. If you get that going better over the course of 6 months, 1 year, 2 year, 3 years, you are improving things. So this is moving in the right direction. So again, I always tie this back to the cardiologists and the EKGs with the patients. And they just so appreciate that. They think my doctor's on the cutting edge. My doctor's on the leading edge of technology and knows what's doing. They just love that. And they love being able to take that right to the patients there. So the ERGs, the EKG, the back of the eye, it doesn't threaten other tests. Oh, if I do this, I can't do that. That's not true. You can do an OCT, you can do fundus photo. Those are structure, and the ERG pairs beautifully with that with function. So tremendous value for ERG. With that, I thank you for your time, and I hope you guys have a great meeting. All the wonderful LKC team, think so highly of all of you guys. Have a great meeting, and I look forward to working with you guys in 2025.